I'm sorry. Oh, I'm sorry, guys. It's not recording. Anyway, that's not. Okay, I felt that from the start. Okay. So it's recording from now onward. It didn't record it before. Okay. So let us get the question. And if it can be for the same case, I mean the CBD and thick, yes, definitely it can be for the same case. So one will be assessing, the CBD will be assessing your knowledge about this case, and the other one will assess your mini-CEXC, will assess your clinical skills. Sorry guys for the recording, but I didn't realize it's not recording, but now it's recording. And anyways, for you, I will not be sharing this record for anyone. Okay, so the mini-CEXC, when you do it in pre-op board round, as I told you, in the AD, if you're consenting like for an off or a trauma patient, if you have a dedicated consent clinic, you can do this in a consent clinic. And I think now many specialties have a consent clinic, like they book 2 or 3 patients at the end of every clinic, especially for consenting. Who can assist you? Definitely a consultant. It couldn't be a registrar or a senior fellow or stuff like that. It has to be a consultant because this is an integral part of the operative procedure. How many can you do? 1 for every critical condition, again by a consultant, but as much as you can do. For myself, as I told you, once I consent the patient in elective clinic or before in theater, before I go to the operative theater, I go and put mini-CEXC for consenting. Again, it has to be case specific, it has to be realistic, and it definitely has to be led by a consultant. Good. So for assessment of mini-CEXC for consenting, you'll see this picture. So have you demonstrated sound knowledge of indication and contraindication specific to the procedure or not? Have you shown the patient alternative for surgery? Have you demonstrated the sequelae of operative and non-operative management? Have you shown a sound knowledge of complication of surgery? Have you shown, explain properly to the patient, relative, and carers, and check that you understand, which is a communication, and explain likely the outcome and time for recovery, and then your professionalism. And again, be realistic, be specific, and try not to go crazy positive or crazy negative. Don't be very generous or very limited. DOPS was direct observation of procedural skills, and there's a bit of confusion between the DOPS and PPAs. And as I explained you earlier, DOPS is assessing your clinical procedural skills, and PPA is your clinical operative skills. So for operation, which needs an operative theater, even a minor theater, it has to be a PPA or procedure-based assessment. But for small interventions, like as I told you, aspirating or injecting a joint, reducing a fracture, suturing the wound, doing a neurological assessment, it could be a DOPS. When to do that? During or after performing a basic skill. It can be a senior colleague or a consultant. How many do you want to do? As much as you can. But remember, every skill which is not a BBA, you have to have 3 forms at level 4, at least signed by 2 consultants. Means a consultant can sign more than 1 form, but not more than 2. So 1 consultant can sign 1 or 2. So you need 3 forms to level 4 signed off by 2 or more consultants. So either every form by consultant or 1 consultant sign 2 forms. So again, for DOPS, anything, because some of the scales, some of the procedure scales are in DOPS, are not in BBA. If it is in DOPS, not in BBA, you have to have 3 of them signed as index scale by a consultant, by 1 or 2 consultants, 3 forms to level 4. Okay. If you need to know, in my lecture in the CESR advice one, I will be showing you what evidence you need to show in the portfolio busway, how many DOPS, what the index procedures, and how many you need to show for every index procedure. But as a general rule, any index procedure needs to be shown either in BBA or DOPS, because some procedures are doubled between them. You don't need to show it twice. So any procedure which you done, you need either a BBA, 3 BBAs or 3 DOPS up to level 4 signed by at least 2 consultants. Can the BBA be under supervision or assisting, or should it be main surgery? Mustafa is again assessing, supervising, operating, training a trainer. This is logbook terminology. In ICP, you need the assessor to be confident that you are doing it to a level of a consultant. So it doesn't make any difference. You was supervised, you was assisting, you was operating, but your assessor has to have the confidence that you are doing this to a level of a consultant. Assessing, supervising, training a trainer, supervise the trainer, scrub, supervise trainer in theater, not scrub. These all are logbook terminology, not ISCP terminology. So what did I do for DOPS? I do it after each on-call, clinic or minor theater. So after each on-call, because there is no on-call without a neurological assessment for CODA, there is no on-call without aspirating a joint, there's no on-call without doing a reduction in the ED or recorrecting a reduction after bone reduction from ED. You have, when you reflect on DOPS, to comment on the technique, on the communication and safety. You need to show that you know the technique, knowledge, and clinical experience. You need to show that you're communicating well, you get a consent from the patient, you communicate with the patient, what is the plan post-op. You have to show that you are safe in your practice. And it started from early in your training for every and each common procedure. So, as I told you, aspirating or injecting a joint, reduction, doing like a suturing, doing like a closure of a wound by any mean, putting a vac dressing, all this can be DOPS. And I advise you to do that in your early years of training as frequent as you can. What you will find in the assessment of a direct observation of procedural skills, firstly, you need to describe the anatomy. And can you describe the indication, anatomy, and procedure and complication to the assessor? And you need to comment on that. Obtaining a consent, communication, preparing for the procedure, knowledge, administrate effective analgesia. Be careful about this. This is a tricky point, because if there is an anesthetist, like you go to ED to reduce a fracture, when the ED consultant will sedate for you. So this will be not assist, because you haven't anesthetized the patient, you haven't advised for any drugs to be given to the patient. So be careful about these tricky points. By the way, comments on the section has to explain anything abnormal here. Abnormal means not assist or outstanding. So if you say no assist, you have to comment here saying that I have an anesthetist anesthetizing the patient, or to say ED consultant sedated the patient. And if you put outstanding, you have to comment here why you was outstanding. This comment section is for the assessor, not for you, but you will definitely write it on his behalf or her behalf. You get my point? So when you say administrating effective analgesia and sedation, you say outstanding, you have to show that, oh, this patient was a pediatric patient with sickle cell disease, and the dosage has to be modified to avoid getting him in a sickling attack. So you have to show in this comment why this trainee is outstanding, or why this trainee wasn't assessed for this scale. So for most of us, this scale will not be assessed, because always you have someone sedating or anesthetizing for you, unless you are in a very peripheral hospital. Demonstrate good asepsis and safe use of instrumentation and sharps, very important for the safety. Perform clinical or technical aspects in line of the guidance, and it's always should be outstanding. Deal with unexpected event or seek help when needs. Complete required documentation, written or dictated. Communicates clearly with the patient and staff throughout the procedure. So BBA is a small form of, DOPS is a small form of BBA. And again, you need either a BBA or a DOPS for every index procedure signed up to level 4 by at least 2 consultants, means maximum 2 forms per 1 consultant. Multi-source feedback, very good, very nice, very easy. All what you need is 11 responses as a minimum. I've done, before I bought the portfolio application, I have 6 MSF, because I was doing it. MSF is the way in this country to show that you are safe, you are good, you are communicable, you are perfect, you are professional. So without going in details, but when you feel yourself unsafe in a place, like you're starting in a hospital, you are not safe, you don't feel yourself safe, you think that they may play with you. So the only way to confirm that you are good, professional, communicable, and safe is to put an MSF. So in my first year in this hospital, I've bought 2 MSF at 1 year, just to show that if anyone comes and say, oh, Mo is unsafe, I can say, no, I'm safe. This is a multi-source feedback. Mo is not communicable. No, I have a good communication evidence like that. My hospital has an old guy which had a lot of problems, old Egyptian guy who had a lot of problems. And when I start here, I felt unsafe that at any time they say, no, this guy is not good, because they were ready to do that. And for myself, to protect myself, I have to have a multi-source feedback. So the multi-source feedback should assess your professionalism, communication, and teamwork. it have feedback from every and each one except patient. Patient feedback makes the multi-source into a 360 feedback. When do you need it? Once a year for your appraisal. You need at least 11 responses, one from each category, which is consultant, other doctors, which include senior and junior doctors, admin or HCA, nurses. So from the 4 categories, you have to have one in each category at least, with total 11 responses. They should comment on your professionalism with colleagues, with patient, showing respect to the staff and the patient, leadership and team participation. Tips for you: try to make a wide range of assessors. Choose as much people as you can. The minimum MSF I had was 34 or 35 assessors or 35 feedbacks, because no one can defend or can attack you when you have a 36 people from the trust at different level: consultant, other doctors, nurses, admin, HCAs, porters, all of 36 saying this man is good. There is no one can argue are not good. You should reflect on all their feedbacks, especially areas of improvement. Be careful about self-assessment, because you will assess yourself and you will get your education supervisor assessing you, because he is the one which will receive the feedbacks before he releases to you. Use this as a guide for BDB and appraisal discussion, and it's very advisable to have one each year for each appraisal. So don't waste your time at the time of appraisal getting like patient to give you thanks letter or writing you a card or whatever. If you have a multi-source feedback, is more than enough for your appraisal. The big boss is the procedure-based assessment. Every one of us look into this, because this shows the whole procedure. So to do a procedure-based assessment, you have to have the knowledge, you have to have the communication, you have to have the skills, you have to have the communication for consenting, you have to have the technical skills or the surgical technique. When do you use it? After performing any surgical procedure. Who can assess you? Everyone, ideally the supervising surgeon or the consultant. You should do that as much as you can, but you need, for portfolio pathway, at least 3 forms for every index procedure signed by at least 2 consultants at level 4. What do I do for it? I put it as a part of the post-operative notes or documentation. So once I'm done with the operation, go to my computer, writing my post-op note. As a habit, I put a BBA straight away. When you bought the BBA after the operation, try to put details like what was the indication, what is specific in this operation, how the consenting went, what was the complication, and ask for feedback even if things went wrong, because it's a learning point. You can comment in yourself saying, I wasn't good in consenting this patient, I was stressed, I have some family problem, I wasn't that communicable. So you can feedback about yourself saying, I've done this mistake, for you to have it as a learning point. So should education supervisor have ICP to be involved in ICP MCF? He may not, but you definitely need him to have an ICP, and this shouldn't be a problem, Amr, because as I told you, there is no trainee in this country who doesn't have an ICP, because they have to show ICP in the ARCP. But if he is not an ICP user, you have the option to send him an email with the forms, and he can approve it and release it to you. I've just joined. Is the meeting recorded and will be available somewhere soon? So unfortunately, Ahmed, for a technical mistake from my side, it's recorded from the middle, nearly the middle or less. So apologies, guys, for that. But it's part of it is recorded, not the whole thing. We can do it again, guys. It's not a big issue. When you go for rating for procedure-based assessment, you will see a pre-op planning, an operative technique, and post-op. Pre-op, he will ask you about, do you know the anatomy and understand the knowledge behind the anatomy? Show if you have a second choice for appropriate materials like II, and this is definitely always assist. Check material, equipment, operation site, marked or not, patient recorded are up to date or not. Pre-op preparation, all this stuff you need to fill, and be careful again. If something hasn't happened, you have to say not assist, and put in the comment box that why is not assist. Like, use general equipment and materials are deployed safely. If you are doing like manipulation under anesthesia and casting, there is no point for that. Yeah. Then exposure and closure, this is different from a procedure to procedure. You need to show what's the optimal skin incision, portal, and access, and all this stuff. Then intraoperative technique, and again, this will be different from one to one. Then post-operative management, how to have the sign outs and all this stuff. And again, as I told you, be careful. This is another trap, is deal with the specimen labels and orient specimen appropriately. Most of your clean operation will not have a specimen. So you have to put not assist and comment here, this operation didn't have any specimen or samples to be labeled or sent. So this is another trap. And assessor, if he finds that all your forms have this assist, he knows that you are cheating. It's not correct, because you're definitely not operating on infected patients only. Most of your patient will be a clean surgery without any sample or swabs. And if you just bought all outstanding, he know that you are cheating. Yeah. So be careful about that. So the two traps in this assessment generally is the point of the specimen and point of drugs. Can we get the PowerPoint, Abdurrahman? Abdurrahman, I can send you the PowerPoint, it's not an issue, but I mean, the information behind the PowerPoint is a lot. So the PowerPoint alone will not give you anything, but I can send it to you, no problem. Islam, for portfolio busway, is it acceptable to have 3 index procedures signed at level 4 straight away, or we should show progress? You don't need to. So if you show progress, fine. If you don't, not. So you don't need, it's not a must to show progress. At the end, he needs 3 forms signed to level 4 by 2 consultants at least. That's it. But if these boxes are ticked, this idea should be trainers' problem, isn't it? Yes. But again, this assessor is a consultant, and he knows nicely that we feel that, not the trainer. Okay. And he will not access any trainer feedback, or not be in contact. He will not reach out to any trainer. He will reach out to you. And as I told you, every question in a good hand will be 2-3 months. So don't put yourself in a place when he will ask you a question. Try your portfolio busway. Take your time, delay your application. This is another advice for you away from ICB. Delay your application, because sending a full application is much safer in time and effort and money than sending an incomplete application and get every 2-3 weeks, every 2-3 months a question. Why that? Submit this for me, give me more evidence about this. This is in good hands. Especially if you have a very busy assessor, it will be 2-3 months. I mean, the specimen box in BB. Yeah, as I told you, it should be your trainer responsibility, but it will come back to you, not to the trainer. Good. Okay, so then observational teaching. I will run through this quickly because we have to take a break to just break Maghrib. So observation of teaching you do for teaching which was observed by the consultant or a senior. Was it formal, informal? Was it formal, informal means was it in a program, in an agenda or not? So informal teaching, like if I stand in the meeting saying, guys, how can we reduce this? Okay, we reduce this in this way, 1, 2, 3, 4, 5, 6. This is informal teaching. But if we have an agenda saying that I'm today teaching the juniors about reduction of distal radius, this is a formal teaching. Type of teaching will be a lecture, webinar, seminar, online, virtual, all the types. You have to briefly describe the teaching session, who was the attendees, and what was the outcomes or objectives meant behind this teaching. Has been performed in a simulated position or not, like it was in a CAD lab, was in like ATLS. All this is forms of simulated teaching. It's not, there is no actual patient. Has this is performance while a course or not? Who was the learners? What was the institutional setting? Number of learners and title of the session. You rate yourself, or your trainer actually rate you about introduction, presentation, conclusion, and professionalism. And assessment of audit is nearly equal the same. So the difference is clinical setting, was it a clinic or the ward or whatever, brief description, basis for assessment, have you submit your results in presentation or report, and was it a primary or first cycle or a full cycle? The requirement for the teaching, you have to show him that you are doing a regular teaching. There is no solid evidence how many teaching sessions per year or per month or whatever. But you need to show your assessor that you're doing a regular teaching, formal and informal, and in a good number of trainees, and you should have the feedback. By the way, the evidence for teaching should be the teaching itself. So if I want to get, if I want to submit this webinar or this session in my portfolio busway, I have to send him these slides. I have to send him your feedback to show that I have done this evidence, this teaching. For audits, you need make it yourself a cycle every year and at least 2 full cycles. So you have to submit 3 full cycles. I'm sorry, 3 audits with at least 1 full cycle. But for to get the full mark of the audit to tick the box, audit every year, 2 of them at least for cycle. You assess the audits regarding to relevance, strengths, standards and target, or what was your guidelines or standard you auditing against, audit methods, results, conclusion, plan for further evaluation, and professionalism. Plan for remember another trap here. Plan for further evaluation cannot be in a full cycle. Okay, so plan for further evaluation if you're doing a first cycle, because this means are you planning to re-audit or not. So if you're doing a re-audit or a full cycle, this should be not assessed. Good. Now we'll go to the other evidence, which doesn't need a feedback. You don't need an assessor, but you need to show evidence that you have done that. I will just excuse you for 10 minutes to pray Maghrib, and then we come back in, what's the time now? So it's 5 to 10, so we shall hear 5 past 10. Should be okay? I will answer this question, then we can stop for 10 minutes. As far as I understand from SSG guidance for portfolio pathway, we need one level 4 CBD or 6 for critical condition and 3 level 4 BBS for injectable procedure. Yes, that's right. Ziad, you need to concentrate. This is what we said. Okay. Yeah, you need 3 for CBDs and mini CEXC and consenting. You need 1 for every critical condition. For BBAs or DOPS, you need for every index procedure, you need 3 forms level 4 signed by consultant, or two consultant, at least 2 consultant for 1 form or 2 forms maximum. Guys, we'll stop for 10 minutes just to pray Maghrib, and then we will come back. Okay. I'll not close the meeting, but just I'll make it mute. Okay, guys. So let us carry on. So we've done with the evidence which need both reflection and feedback, reflection from yourself and feedback from your trainer or assessor. Now we'll come to the evidence which doesn't need a feedback. So you don't need to have an assessor, but you need to have an evidence that you have done this. And this is basically just a store for all your practices and activities. So they make this on ICP just to keep all your evidence in one place. So rather than keeping evidence of audit, evidence of teaching, evidence of management, evidence of leadership, evidence of meetings, conferences, in everyone in place, they keep all in the same place with the evidence supporting them. And they get you to reflect on them to understand that you have all what you need to have from this activity. So, I'm sorry. So coming to the audit, okay, you have to add all the audits which you haven't been assessed for, means you wasn't the audit lead. So if I was an audit lead, so I will get my assessor to put me an assessment of audit. Okay. If I wasn't the audit lead or the audit presenter, I didn't have a main role in the audit, like I was a co-auditor, I can edit it here and both the certificate I will receive about the audit here. Award and prizes. So you need anything. You don't need to have the Oscar, but all what you need to have is a recognition. Like you received like an recognition of your role in an audit, recognition of your role in presentation of a conference, recognition of you have been nominated for award, you haven't been awarded the award already, you have been nominated for something, you have received an appreciation letter from clinical lead, from clinical supervisor, from chief of service, saying that your clinical practice is outstanding, your communication is outstanding, you have this, you have that. So this is all is form of awards. Yeah. So it's not formal, because formally you have to have an award, but you can still add them in that. Courses and e-learning. Under this course and e-learning comes number one, all the courses, and basically the fully approved courses. You will have all the information on the system. So like ATLS, ALS, CRISP, basic surgical skills. You don't need to add more because the form will have a space for them. But you can add any course. You have any course, any e-learning, any webinar, any online. And the more you add, the more shows your up-to-date knowledge, the more shows how you dedicated, committed to progress and improve your portfolio. Exams and all forms of exams, you can add it here, Part A, Part B, MRCS, FRCS, postgraduate, whatever you have. External conference and meeting. For the portfolio busway, you have to show that you're attending at least one international conference every year, which you can use this is a good point for the IMGs, because you can use your back home conference as an international one. So like you can, for Egyptian Orthopaedic Association, you can attend the Egyptian Orthopaedic Association conference, and this will be calculated as an international conference. And I support you in this, and I've sent on the groups, and anyone who want to present, anyone want me to support him to attend any of the conferences, support him with research, support him with something to present, I'm more than happy to help all of you to have an international conference input each year. Internal meeting and teaching attended. You can add in this all the internal teaching, all the M&M, all the educational half days, all the clinical governance days, all the departmental teaching, all the departmental journal club. All this goes under internal meeting or teaching attended. Any one of, because I know now that Ahmed, my registrar, is on the call, Islam is there, Wahb is there, all the people with Audit the trust, they know that we run every month a journal club in the foot and ankle team. We have educational half day every month. We have M&M, audit day, research day. We get some of the companies to show some hands-on and so on stuff. This all should go under internal meeting, and all what you need as an evidence for that, like an email, like an agenda, like an approval from a consultant, like because you definitely, for every educational half day, you receive an email from the educational half day secretary or coordinator. This email should be an evidence enough that you have attended. And definitely, if you have like a certificate or a letter saying that you attended this workshop or this so on, you can add it. But you have to add every internal meeting there. And as an NHS appraiser, I can tell you that to get an appraisal, this gives you have, every department should have at least 10 educational half day a year. Each half day is 4 hours. So you have 40 hours of learning, internal learning, which gets you half the way to your appraisal. And in the portfolio busway, imagine that you are submitting evidence for 6 years, means you will have 240 hours of internal teaching or learning, which is more than enough. So if you only add in the internal meeting and teaching your educational half days, but you add them regularly every month with a good evidence like an email or a certificate or appreciation letter or whatever, this ends you at the time of applying for portfolio busway by 240 hours, credit hours of learning, and for the appraisal yearly, about 40 hours of learning, internal learning, which is good. Patient feedback is very important, and patient feedback can be word of mouth, can be thanks letter, can be letter to pals, can be email, can be everything you imagine. So any evidence, any piece of evidence you can get, you can put as a patient feedback. And this is a very, very good evidence that you have a good communication and professionalism. We don't have, Rami is saying, we don't have official department teaching at our hospital. What are the alternative? But yeah, but you definitely have an educational half day. If you don't have an official departmental teaching, agree. Tip and trick for you, Rami, you can make it. You don't need it to be there. Means go tomorrow, put a plan for departmental teaching. The guys which is working with me in the department, in the trust, they know that we nearly invented the audit, we nearly invented the research, we really invented the journal club, we nearly invented the educational the workshops on the educational half days. So for you, Rami, you definitely have educational half days in your department. This is not an option. It must be there, which contains a clinical governance M&M and audit and research meeting. This is in its own calculates about 40 hours a year, which is 240 hours in the 6 years for portfolio pathway. If you are more proactive, if you are more productive, you can start putting some departmental teaching. Because if you go with an agenda for departmental teaching agreement from your colleagues and consultant to teach a place to teach in and go to your management of the department saying, I have this plan for teaching, they will be grateful. They will never say no. You get my point? And this can calculate for you as a management, can calculate for you as a leadership because you leaded the idea, and can calculate for you as a teaching. I think it's a part of audit day. So if we have some teaching in it, we can submit. Yes, you can submit that. The audit day, the educational half day, the M&M day, the clinical governance day, all are the same. It's the same meaning. It's an educational half day a month, which all of this should be discussed in. You can use it as an internal teaching. And again, my tip to you, go and invent it, get an agenda, just simple stuff like teach on neck of femur, distal radiuses, how to catch a compartment, how to diagnose a coda equina, and make like 5-6 teaching sessions. Get some of the senior registrar and consultant to do. Get the juniors to know about it. Find a convenient place to do that, and go to the manager saying, "This is my plan for a teaching, and I believe and I'm sure they will support you." And you can submit this at that time as a leadership because you lead on that. You can submit as a management because you are planning, supervising, and running, and then you can submit it as a teaching, both attendance and a teaching and the teaching reflection. And definitely the tip for all of you if you don't have that teaching in your department. Then patient feedback, as we agreed again, patient feedback could be a word of mouth, could be a letter, could be an email, could be a thanks card, could be a gift, could be anything. And if it's a gift, you can put the evidence as a photo of the gift. So I receive a lot of wine. So, and I don't use them. So basically I just get a photo and put it as an evidence. But you have to make the photo into PDF because it doesn't accept JPG. Position of responsibility. So this is every management role you do. And if you, again, I'm sorry to say that in our old culture, this is not that very clear for us, but actually, even if you don't feel that, you do a lot of management every day. How comes? Yes, you do. I promise you. So you manage your on-call. You manage the team of juniors in the on-call. It could be a management. Could be added as a position of responsibility. You manage a rota. If you're managing a rota, it's a position of responsibility. You manage the audit and research. It's a management or a position of responsibility. You manage an M&M, it's position of responsibility. You manage a journal club, it's position of responsibility. You do the tip I've given to Rami now, and you invented in the department a departmental teaching program, it's a position of responsibility. I can say to you, you manage your house, you manage your home, it's a position of responsibility. But don't go so crazy on that. Just be as more professional as you can. So how many a day, how many management or position of responsibility you do a day? A lot. But just look in it and see where do you need the management skills. This will be where the position of responsibility is. Okay. So when you finish an on-call, like a senior registrar, looking after a team of like 2 F1s, 1 F2, 1 TMB or PBA or whatever, ABB. So you can go and put this as position of responsibility. I was the senior on-call registrar today. I was managing a team of 134, and this is my reflection on this position of responsibility. If you run a meeting, if you're conducting a meeting, the people who comes with me now in the new OrthoXcel or old OrthoBima, they know that I send them a reflection certificate, a management certificate for everything they do. If they are managing group, WhatsApp group for me, if they are conducting session, preparing feedbacks, doing anything. And I remember the last batch was 7 or 8 who received the management certificate from my side, and all was accepted for training and all was accepted for portfolio as well. Does leading a theater list go under position of responsibility? What's meaning by leading a theater list? Because the is about the definition. In the theater list, you don't lead, you operate. As a chief operator or the main operator, this is not a position of responsibility. But like, imagine if you are organizing the theater list in the department. Yes, it goes as a position of responsibility. But operating, no. Or leading a theater list as operating, no. It's not a position of responsibility. But imagine that I'm the one who do all supervising all the trauma coordinator work, like where to put this, when to put that, who is the person to do that, who is the person to do this. I'm getting the people who are arranging the kits and arranging the stuff. This is a position of responsibility. Or is it better to put in somewhere else? Now, if you're leading a theater, it's a PPA. It's nothing else. And if you have anything specific, like I had a discussion with the anesthetist, this can go under case-based discussion. I have a discussion with my senior, it can be as a case-based discussion. If I'm operating, it's a PPA. You get my point? If I'm doing a simple scale, like I go with the anesthetist to do a block, it will be a DOPS. You get my point? Some I remember some who go and who go with the anesthetist to learn doing some blocks. You can get the anesthetist, consultant anesthetist to sign this for you as a DOPS. Operating is a PPA. So imagine in one theater list, you can fill all the forms. So organizing the theater list, getting the kits, ensuring that every list is well stuffed and will have a well priorities in changing the cases and stuff. This is a position of responsibility. Operating is a PPA. Doing a skill with the anesthetist is a DOPS. Getting a consent in the morning is a clinical evaluation for consenting. Have a discussion with the patient about shared decision and choosing operative, non-operative, and the stuff. This can be a mini case. Discussing your consultant about the case you're going to operate can be a case-based discussion. So you've done all the formats in one case. It's again more of mindset. As I told you at the start, is not about the formats. My mindset can give me the chance to fill all the formats in one day. Let me show you this again. Imagine I'm going today to, no, we'll go with an actual example. Yesterday, I have an elective list and I have 3 patients. One was one was an ankle scope, microfracture, lateral leg reconstruction, internal bracing. The second one was a 4-foot reconstruction in a young man. We correcting hallux, then doing an MIS for a hammer toe. Then the third case was bilateral fusion for first MTB and correcting hammer toe with MIS. Okay, Islam, one of the attendees now, was my registrar. Okay, what can Islam do if he? What could have done Islam if he wants to make all the formats, if he has a mindset? So in the morning, he was with me in the car, so can easily start discussing me about one of the cases. So saying, okay, lateral leg reconstruction, what about the lateral leg reconstruction? I'll ask him what is the anatomy of the lateral leg. We start speaking about this, we start discussing this. He can submit this form for me as a case-based discussion. We reach the hospital, we've consented the patient, he can send me a form about clinical evaluation for consent. One of these patients, the guy with 4-foot reconstruction, the young guy, I discussed him a lot about the MIS. So I've done the hammer toe completely MIS, minimally invasive for him. Islam can easily submit this to me as a shared decision making or a mini case. Okay, he can ask me, Mo, can you just evaluate my assessment of 4-foot deformity and go and examine the patient and can build this as a case, a mini case. Then we go to theater. We have a briefing, and briefing he can put as an evidence of communication. Then we go into the theater operating. I leave him to do like first MTB fusion. He can submit this as a BBA. Then while he's doing that, there was like when we was doing the MIS, the scrub nurse wasn't familiar with the kit, so she doesn't know how to play the bear. So we can put this as a critical incident. Okay, so Islam could have done 7-8 forms from a single list added to the local money he got. So I mean, it's a mindset. It's not about how to do it. I can fill this portfolio to you in few months if you have this mindset in your mind. If you're going in the morning, planning to reflect on in everything in a positive way, all these forms are clear in your mind, what each form is used for and how to fill it. And then you can get assistance from ChatGPT or whatever, but in the way I have explained you, not a complete machine writing. Get ChatGPT to rephrase, reformat, make it in a proper way, make it in a good language. That's it. So it's not difficult. Come back. So position of responsibility we spoke about. Then presentation is very important. So everything you present, a case in NDT is a presentation. A journal club last week, all the juniors, no single junior on the call now hasn't done a case presentation in MDT. Yeah, this case presentation can go under presentation and under case-based discussion at the same time. And I promise you, all of you have done a lot of it every day and never think about putting as a presentation. Then you have a regional presentation like in an MDT. You have a national presentation like in a meeting or a conference or online, and you have an international presentation like if in a big conference or a big meeting. What do you need for a portfolio busway or RCP if you are a trainee? You need to show that you are doing a regular presentation locally and regionally, and you need to have at least 2 international presentations in 2 well-recognized conferences, and you should show an evidence of the presentation itself, certificate, and the agenda, showing your name, saying that you are presenting this as a podium or a poster. So presentation, super easy. And you can manage the local in this way, I've told you. So coming from each and every clinic or a MDT or a trauma meeting, you definitely in every clinic went to your consultant and discussed the case. This case can be a presentation. You can ask him to approve this as a presentation to you if you do a proper presentation of the case, not asking him for an opinion. Like, I've got a case. I'm a foot and ankle consultant. I'm doing a foot and ankle clinic. We got a case. Ahmed remembers we got a case of a distal radius fracture operated by someone in the trust, which went the wrong way, and there's a bone reduction. And I may ask him to go and present this to an upper limb consultant. If he goes formally, present this case to the upper limb consultant with all the details of the patient, this could be a presentation. Okay. And no one of you haven't presented a case in MDT. No one of you haven't presented a case in M&M. No one of you haven't presented a case in educational half day. No one of you haven't presented an audit. No one of you haven't presented a clinical governance. Anything of this is a local presentation. And there is no number for this. You need to show that you are doing this as a regular activity. Coming to regional, if you are a trainee, you definitely can do that through your ordinary, and you're definitely doing this teaching every week, and you definitely sharing this. Nationally, if you can. If you cannot, just be back to me. I'm happy to help you to present in one of the conferences internationally. I'm happy to support you with a presentation. I'm happy to support you with a research, to add you to my research team and get you to present. Everyone on the call which is done a research with me, Ahmed, Jalem, Mohamed, Spishi, everyone have got an option to present in CCOT, in E-Fort. Hussam is presenting in E-Fort. Shalan is presenting in BOFAS. Islam is presenting in BOFAS. Bishbish is presenting in Egypt. Hatem is presenting in Egypt. Hatem is presenting in CCOT. So I'm more than happy to support you in this, and it's not difficult. So don't worry about this. Questions. How to prove presentation on ICP, and I told you. So if you the formal presentation, which is mandatory, like the international presentation, you have to have 3 pieces of evidence. Not all of them need to be on ICP. ICP will accept 1 evidence. So my advice to you, if you need to submit the 3 evidence and release your mind, merge them 3 in 1 PDF and upload it to ICP. What the 3 evidence are for an international presentation is acceptance email or certificate. So either they send you an acceptance email for your presentation or certificate that you presented, agenda or program of the conference showing that you are presenting, and number 3, the presentation itself, the slides itself. Merge 3 of them in 1 PDF and upload it to ICP, and you're done. Do we need presentation international meeting for portfolio busway? Yes, you need at least 2. Can we have your email to get in contact for research? Guys, you have my email and you have everything. I don't think there's any orthopedist in this country is more exposed than myself. So this is my email. Amr, if you are not in our groups, we have hundreds of groups. So, and since you know about this, you did know about this lecture, you're definitely in one of this group. This is my email for OrthoXcel. This is my personal email. It's my mobile number. And has a WhatsApp on it. Hopefully all this will be helpful. Okay, what else? So questions wise, can publication be considered as a presentation? Definitely, because you have to present the publication. But publication HEBA is, publication will go. So if I have a publication which I didn't present, it is a publication. I have a publication which I presented, it is a presentation and publication. So, and normally no one will have a publication without presentation. It may be the other way around. I present research work minimally 10 to 15 in different conferences a year, but I actually publish 1 or 2 of them. So you may have a presentation without publication, but it never happens the other way. There is no one who will publish without presenting his paper, his work. If I present more than 1 case in a single MDT or M&M, can they be counted more than 1? It could be counted, but will not be that valuable. So MDT and M&M will never finish. So you get my point? So it doesn't make any sense to waste your time putting 2-3 cases in 1 M&M or 1 MDT. It will calculate, but it won't be that valuable. So my advice to you, have it 1 case for every M&M or MDT. شباب احنا عايزين بس دعاء. Don't worry about thanks. It's all orthopedic research that you conduct, Mr. Mohammed. Yeah, surely Hiba. I will not conduct a general surgery, but it's all yes, Ahmed, it will, but the record will not be from the start. And again, apologies, guys, it's my mistake. Coming to the project. So the project could be a research project, could be any project you imagine. Like my non-linear trainee project is a project. Mohamed-Hashem is helping me in this. He prepared the presentation and he was with me when we presented to the Royal College. You can have a project like I advise Rami to do, like a project of inventing departmental teaching in general surgery department in Wexham Park Hospital. You can have any other projects you imagine, either granted or not, either funded or not, but it is in the process of project. And the project, he will ask you, is it processing, completed, or published? Okay. The commonest for us as a professional and an orthopod is a research project, but you can do any other project. I know people who are invented screw length measurement device, people who are inventing in AI at the moment, making machine learning and making large language modules and stuff like that. Any project that you feel that it will give a valuable result, you can put it in the project. Okay. A course, a meeting you are planning and conducting, it could be a project. Is it still the 2 weeks submitting to ICP rule apply to presentation? No, because presentation, they know that the day of assessment is different. Means I can get an acceptance email today for a conference. I already got an acceptance email a few days ago for CCOT conference in September. You get my point? So no. So this evidence I'm speaking about now doesn't have a feedback. So there is no time for assessment. The 2 weeks doesn't work here. Get my point? 2 weeks window works for the where you submitting for assessor. This evidence is not for assessor. So the 2 weeks doesn't work here. The 2 weeks works for the evidence, not for the other evidence. Publication, it definitely publication, and you have to have, it doesn't need to be a PubMed index, but you have to have a journal. You have to have a DOI, or have to have a link for the publication. Okay, even if it's in a local journal, local magazine or whatever, but it have to have has to have been published. There's no option like it will be published. Okay, he will ask you, is it accepted, is it submitted, is it published? But if it's not published, it will not count, so don't waste your time. So I've submitted and it is rejected. If I put it on ICP as submitted, doesn't make any count. Yeah, so don't waste your time. So put in publication what you already published. Unless you have nothing published, you can use the submitted and accepted. Get my point? So play with it. So if you have publication, there is no point to add any paper submitted or accepted because it doesn't make any sense. Put it only when it is published. But if you have no publication, don't keep this is vacant. Add some which is already accepted or submitted only. Yeah, it will not count a lot, but it makes some evidence. So rather than keeping it completely blank, no, add some which is accepted or submitted. But if you have publication, don't waste your time on putting submitted and accepted, but only the published. Must be no, it doesn't mean PubMed is needed for portfolio busway, but ICP no. You can add anything on ICP because it shows your research experience. But for portfolio busway, you need the tick box is to first author in PubMed indexed. This is the ideal answer. يعني is يعني إجابة المدرسة، إجابة كتاب المدرسة. But is not a must. Means as an assessor can accept, like if you published 10 papers as a second author in a PubMed index, he will definitely accept as a research experience. If you published 3 papers in PubMed indexed as fourth author or third author, if you submit 2 in non-PubMed index as first author, it's a research experience. If you're attending a very regular journal club 6 times a year, it's a research experience. If you're reviewing for few journals, it's a research experience. And if you both this collectively, he can take your box for the research. But we agree, we always go with the ideal answer. Ideal answer is 2 first author of a paper published in a PubMed indexed journal. You will take the box of research. He will not look in any other evidence. If you don't do that, you need to show him a proper evidence that you have a research experience. You get my point? So someone who is second author in one or two papers non-PubMed indexed journal, have a reviewer experience, is attending journal club regularly, is collectively, this is a research experience which he can satisfy the assessor. But what makes the assessor just tick the box without thinking? If you have 2 first author PubMed indexed papers submitted in a PubMed indexed journal. You get my point? If you cannot reach that, or because this takes time from the people who do research, they know that this takes time, you can try and fill up as much as possible from the evidence. I've myself tried to help you with the regular journal club, which I'm not sure all of you attend and know about or not. So we have the EOA, also PEMA journal club, which is conducted every month we've conducted for the last 7 months. This is the 8th month. I've made it absolutely for you. So I leave you to attend, to present, to organize. Mohamed.Hashem is the organizer. Is looking after that. You can speak to him or you can send him. And I approve for him the speakers for every cycle. July, we're done with the 2nd cycle. So 2 cycles already presented. We present all our PubMed indexed in the BJJ papers and presented by Egyptian orthopedic surgeons in UK. So it's from you to you. So, and it is international because it has a signature from myself and from Professor Al-Ashab from Egypt, for the Dean faculty, the Dean of Faculty of Medicine of Banha. So it's calculated as an international journal club attendance. And I give you a certificate after a feedback, which is approved. So it shows you have a journal club, regular journal club attendance, but unfortunately it's not very regularly attended. So sometimes they are 40, 50, sometimes 30, 20, 40, 60. So it means it's not consistent, but it's honestly is a very good chance, which you have to use. It's up to you, absolutely up to you. I'm doing my best, but I cannot push every one of you to attend. By the way, journal club doesn't need to be orthopedics. So if you have an access to attend, journal club and other specialty, absolutely fine. But definitely related to us. Don't attend Ops and Gynae and say that I've attended a journal club. So for journal club, guys, you can attend the EOA, but also be my journal club. It's run every month, very regularly. Hopefully, it will be very regular, inshallah. It's already, this is the 8th month, so 7s are done already. So, and you need to show in your portfolio pathway that you attend journal club 6 times a year. Not need to be consecutive, but 6 times a year at least, to show that you are keeping with updated evidence. Research, presentation, I can help you with. Reviewer and journal, I can help you with. I have access to 3-4 journals to put you as a reviewer in. I can help you with presenting in international conferences, as I told you. I can add you to a research team. We have presented, so by the way, Hatem and Mohamed, we have run a national QIB, and we put it on the audit and research group for OrthoXcel, or the new OrthoXcel, and we asked it for contributors, and not every one of you shared, and even the contributors wasn't very committed. The people who are committed, we finished a multinational study in 10 NHS trusts with 240 participants, and paper is prepared and is going to be published in BJJ within 2-3 months. So in 6 months, we succeeded in OrthoXcel to get IMGs to publish a paper without any effort on a big QIB national study with 10 NHS trusts, 204 responses. And we have another project running now about foot and ankle survey, and we will run more and more projects if you are interested in. So we're nearly offering you everything we can offer, so just help yourself. Then the group for research, I'll send you all the groups, all the group, Rami. So all of you now have my number. Anyone who is want to share we have group for everything you imagine, from SHO juniors, ST training application, ST interview mocking, FRCS part A, FRCS part B, portfolio pathway, CESR advice, consultant interviews, everything, job network, audit and research, everything you imagine. So anyone who is missing a group, just send it to me and I'll add you to. But you have to be prepared for that. It's true. XD, I didn't get that from it. XD, I'm a bit old man. I'm not so good with the technology and terminology. Many groups. They are too. Imagine you are confused with many groups. What about who is managing them? So guys, for OrthoXcel, other than my group, my other work, my private work, all this stuff, they are 13 groups for OrthoXcel. So you have to excuse me. Good. Research, teaching session by a trainee is very, very important. And again, every teaching you have done under a supervision, put it as teaching session. Significant event or critical incident is very important. And you have to show at least that you have been involved in some significant incidents or events, and how did you manage this and how did you do in that, and it's very important. Definitely every one of you has had an incident, have had a complaint, have had a comment from the nursing staff, has bought a form and ethics or an incident form against staff, against equipment, against lab, against ED. You have to take a copy of this, put it on ICB, reflect on it, and make it as a significant event or critical incident. It's very good to show that you are regularly involved in this. Definitely not having a complaint every day, but like I tend to make it once in every appraisal year. So in every appraisal, I have my event profile free. Fortunately, alhamdulillah, over the 5 years in UK, I never had a complaint. I never had an incident. I never had anything in my event portfolio. I go and put an incident form and reflect on it on ICB once a year for every appraisal year. Miscellaneous, this is like, you know, a universal form. You can add anything else you feel that it will support your portfolio. So don't waste it. Try to use it as much as you can. Guys, you need to spend some more time on ICB. You need to spend some more time on reflection, some more time on documentation. I know it's not our normal practice, but we have to correct this. Honestly, I'm very, 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 very Egyptian, and I'm very, very, very standing behind our values and our concepts and our regulations. But honestly, reflection and ICB and documentation is something we're missing. We have to be honest to ourselves. This is something missing in our learning module in Egypt and in our countries. So we need to learn how to do that, and we need to spend some time. We need to push ourselves to do that, because it's not easy. Until it becomes your habit, it will be very simple. And the moment you know how much you achieved, the moment you will want to apply for anything, and with one click, you find that all your evidence is in one place, is written very well written, it has an evidence, it has a good reflection. This is the time you feel, oh, perfectly, I'm very well done to myself that I did this. And the other moment is if you're done with the exam and then to come think about portfolio busway. This is the time you will realize how much you was rude to yourself, because getting the evidence just all around the place everywhere and trying to collect this for a portfolio busway, super painful, super painful, super painful, I promise you. If you don't have proper ICB, proper reflection, proper documentation day after day, and you need to do this retrospectively in few months, I can tell you that CESR busway or portfolio busway, one of the difficult points of your life. But if you have ICB build up regularly and progressing from day-to-day practice, it will be a piece of cake. هل الماجستير والدكتوراه ليهم أي تقل on evidence? Definitely, they are examinations. They go under examination, but they do support, but they don't make a difference, to be honest with you. So they will not, the one with MD opposite the one who is not MD in a portfolio busway, at least, I don't think this makes a big difference, but definitely gives you an extra point. Sorry, may I missed from the beginning. Submission of evidence include last 6 consecutive years. What about any gaps? They accept the gaps, which can be explained. You get my point? So the people who are applying now, they have an explanation about the gap in 2020, which is a gap of COVID. So gaps are acceptable in ISCP when you apply for the portfolio busway. You don't need the 6 years to be consecutive if you have an explanation. You get my point? Like I've gone, not me, a lady who went in a maternity leave for 6 months. She can still apply for 6.5 years, which means 6 years of practice, because she has a 6 months gap, which is explained. COVID is a good explanation for 6 months. So you can apply today. If you want to apply today, you can apply back up to mid-2019. And you write in your cover letter that from this date to this date, I was redeployed to doing ITU stuff or whatever in COVID, or was this time I was a high risk for COVID, I didn't go for anything. For any overseas resident who is planning to apply for ST3, how to manage ICB? Start today. So it is as it is. You cannot do anything for the past. You can change the future. You cannot change the past. So put your evidence from today on ICB. The other evidence is non-ICB, the old evidence. Try to collect it on paper, but you have to collect the evidence. You cannot, it's not acceptable to go without an evidence. Otherwise, the people who had applied for ST3 application last year, they know that. The more evidence you gather, the more score, the more support for yourself. For interview, you can be attacked in the interview, but if you have a strong application, this makes your position much better. So start from today for us to put everything on ICB. The old evidence, get it on paper. Past evidence from before counts. Yes, it does count definitely, because so much was accomplished. I'm not sure what you mean, but everything counts. Everything counts. Okay. And we're running, guys, an ST3 application orientation session on 14th of June. So the morning, 10 to 4 will be the CESR busway for the seniors, and then 8 p.m. will be an orientation session for the juniors. We're collecting for you the experiences of all the applicants who passed and who didn't pass, and how did they feel about it? How can you improve your ST3 portfolio and application? And how can you improve your interview? So it's a very, very, very important one to attend for everyone who is planning for ST3. Just for confirmation, we don't need formal placement for pediatric and spine. If we can still get the relevant CPDs, yes. But you have to show him that you have done this in a proper place. Means not a placement, but you have to show this in your contract or in your rota. It's not only the evidence. You don't need a formal placement. It will be very clear. But you need to show him, like, I cannot say that I've done all the spine cases, CBDs and BBAs and all this stuff just haphazardly between the days. No, I have to show him that in my contract I was doing a spine rotation, or I have in my rota like regular spine clinics for a certain period, like 6 months or more. So you don't need a formal placement, but you need to show evidence that you had this practice and you have this evidence. This you can show from rota or from contract. Back to the point for the 2 weeks window PBA submission, is it acceptable to justify this as it wasn't paid for that period, and as soon as I paid, no, you can justify you didn't pay. You don't need to justify, but it doesn't make sense if you are the assessor and this trainee has 2 years of ICB, 6 months of paper, then 2 years of ICB. It doesn't make any sense. He wasn't rich, then become poor, then become rich. It doesn't make sense. But if I've used ICB till today, and I started using it from today, and for the last 3 years, I don't need to explain to him was it paid or not. I wasn't using ICB, and this is my paperwork. You get my point? But where's the problem? The problem comes if you're normally using ICB, then for a time period you are not using ICB and you're using paperwork, and then you use ICB again. This is when the question will come. But if you're not using ICB at all and you present all your evidence on paperwork, absolutely fine, no problem. If you don't use ICB till like 3rd or 4th year of your portfolio busway way, and you show 3-4 years with paperwork and then 2-3 years with online, absolutely fine. What doesn't make sense is you say, oh, I was paying for ICB for these 2 years, then I wasn't paying for 6 months, then I start to pay again. This doesn't make sense, neither for him nor for you. Can you post the link for the upcoming Zoom meeting for the ST3 training application? Mustafa, again, guys, because I cannot put every link here. So you have my number, you have my email. Everything is on OrthoXcel website. Message me privately saying, this is my name, this is my designation, this is my hospital base, and I'm applying for ST3. Please add me there. A very important point, guys. If you go for a group which you are not interested in, like we from our old culture, we like to be added in every group, in every free group. So if I'm a junior and I'm asked to put myself in a CESR advice or in a consultant advice, interview advice, what will happen? I will come to the point, I'm not following the messages anymore because I'm not interested of it. So don't worry, all groups will be yours forever unless I'm not there. If I'm still there, I'm still alive, all these groups will stay still going on. And you can use every group when you need it. So Mustafa, WhatsApp message me privately, your name, designation, and hospital base, and what is your level of training or what you're applying for. If you're applying for ST3, I will add you to ST3, add you to the OrthoXcel main group, and add you to the ICB and stuff like that, audit and research, which I will find is of your interest. If you are a senior, I can add you to the CESR advice, add you to the consultant interview advice, stuff like that. But the easy way to have all the links and everything, just if private WhatsApp message me on my number. Guys, this is end of it. Thank you so much. I know it's very long, but I'm sorry it couldn't be shorter than this. I prefer to go through each point step by step, what is needed, what is mandatory, what can you do, how can you do that, my own personal experience. I hope it was helpful for you. And again, I hope I'll email you feedback forms, and I hope all of you will fill these forms for me to improve it next time, and for yourself, to do anything more. If you want me to speak about anything more, I'm more than happy. Again, guys, I don't need any thanks from you. All what I need is just prayers. Just pray for me, and hopefully Allah will accept that. And wish you all best of luck, and have a very good evening. And Hamid, about certificate of attendance, I can submit you. I can supply you with a certificate of attendance. So in the feedback form, I will keep a point to ask if you need it or not. If you need it, I'll definitely do it for you. Guys, all the best, and please, if you feel you need anything, please come and contact me. I'm more than happy to help you at any stage, and all what I need from you is dua. Okay, good luck and have a good evening, and thank you so much.